So good evening all the training, NNF trainees and students. Welcome for this session of NOEL session 4 and today's session 5. This last 4 sessions we have done respiratory module. So different aspects of ventilation, neonatal ventilation we discussed. To start with, begin with, we discussed neonatal resuscitation. Beyond that, next 3 sessions were how to initiate ventilation, and if not to ventilate, how to optimize CPAP, and if I ventilate, how to get the best result by using the patient triggered ventilation. After knowing that, we move today to another session of neonatal ventilation where the evidence is very strong across all the mode of ventilation. This is the only probably proven mode of ventilation where we know no ventilation is physiological, no ventilation is safe unless done gently, unless done for brief period after knowing the baby's condition, knowing the ventilator. But among the ventilators, among the devils, probably this is the least amount damage causes to the baby. So to know that, what are the advantage of this volume targeted ventilation with any of the ventilator setting for the different disease pattern of the babies. One of the disease, how to optimize the volume target, maybe you will learn today's presentation, which is the clinical bedside case presentation. But through this session, we will learn what are the ways the volume guarantee or volume target ventilation better than other patient triggered ventilation when we add it to the patient triggered ventilation, and among different use, which is the best one, which patient triggered ventilation will be best suitable for this volume targeted mode, and what are the benefits for the beginners and for the practitioners. Equally, academically and practically, both practice points we want to learn here. So to continue the session, today the presenter, Dr. Kirtana, she is an NNF fellow from Paramita Children's Hospital, Chandanagar, Hyderabad. She is fellow student who is training, who is going to present. She is going to present the case bedside and a brief introduction about volume target ventilation. And moderator, Dr. Jagan Mohan, who is a neonatologist from the Paramita Children's Hospital, same hospital. He is there to guide. He's guided the student, and throughout the session he will be there. Beyond that, two of the eminent faculties, Dr. Bijan Shah, who is a professor of IPGMR, the complete name I am not taking, is a university hospital with a highest number of neonatal admissions with the ventilator facilities in the country, with the biggest experience, with so many academic interest in non-invasive ventilation and volume guarantee ventilation. He is there, Dr. Bijan Shah, he is there to guide us throughout the session for the students to learn what are the practical aspects and the evidences about the volume guarantee through this interactive session. And another eminent neonatologist, my dear friend Dr. Rajat Atre, he is a well-known academician, is across the country among the neonatologists, is a very popular speaker in different conferences, NNF, IIP, NEOCHAP, any of the conferences you'll see his talks are very, very engaging. So we got him today. We both of the faculties are very experienced. They will guide us through this session about the volume guarantee. And to supplement, my colleague Dr. Nitasa also available here. So I begging my apology for my voice today. So I won't be full session. I won't be there. I will request Dr. Nitasa to carry forward in the meantime the session, taking the questions of the students and running throughout the session. And in the meantime, before starting the session, before requesting Dr. Kirtana to go ahead the presentation, I will request both the faculties to just one introductory words, what we're expecting from this session, to talk to the presenter and the students, and request the students to equally participate by posting questions throughout the session. So end of the session, we'll take those questions, try to sort out the answer through the wisdom of our faculties and the moderators. Thank you all. Let's begin the session with the faculties' inputs. Both the faculties, Dr. Bijan Shah and Dr. Rajat Atre.
Good evening, everybody. I think over the last decade, what we have seen more and more, we are doing non-invasive ventilation. But I think all of you will agree with me, sometimes some babies still require ventilation. And mostly the babies who require mechanical ventilation, these are late preterm and term infants. And when we were using ventilation previously, with the last decade before that, we are using patient-triggered ventilation. As Dr. Nalini has rightly said, the volume is more than the pressure. So now the concept of volume guarantee ventilation has come in neonatal practices. And over the years, people are using volume guarantee ventilation. But if I am not wrong, many times we see that volume guarantee ventilation, there are some issues Like when you start volume guarantee ventilation, the ventilator keeps on alarm low VT, low VT. I think this is one of the few reasons the many clinicians actually they do not start volume guarantee ventilation. But actually we should know actually what we should do in volume guarantee ventilation. When that means we should know of the ins and out of volume guarantee ventilation. Once you are familiar and comfortable in volume guarantee ventilation, it be good. There are certain things we will discuss because most of the ventilator we're using like Babylog 8000, then VN600, Hamilton, etc. One of the important, I think this will be discussed when we come across the session. Uh, is that sometimes we'll find that when you start volume guarantee ventilation, if the baby is not able to generate, even the baby is generating that much of volume, but the pressure is not delivered. That means that PIP comes to the PEEP level. I think these are the certain issues, and that it becomes a problem. What we do, we increase the volume, but there is a limit of increasing the tidal volume. We cannot increase the tidal volume. Even after increasing the tidal volume, ventilator still gives alarm, and baby gets exhausted by increasing the respiratory rate. I think these are the few issues we'll discuss when we, as the case progresses. So there are many practical aspects that thing the student should benefit once this after this session is over. So my suggestion is, my point is that we'll learn when to use volume guarantee ventilation, which babies to ventilation, what are the settings we have to use, and what are the problems and troubleshoot what when there is when you are using volume guarantee ventilation. With these few words, I want to end here. I think we'll discuss more and more once the session starts. Thank you very much.
Hello, good evening. I'm looking forward to an interesting case presentation. Um, so we all know that it makes physiological sense to have volume targeted ventilation. We do know that the studies are showing that the outcomes are better, but we need to understand the mode of ventilation that we're using. Just because somebody has said it is good or some study has said that things might be better, may not be the reason to use it unless until we know how to do it. So we have fantastic machines now and we have babies, but still the interface between the baby and the machine is you. So I think more than the machine, I think we need to know exactly why things are happening. So the doctor said there are lots of times that people say that I really love volume ventilation, but my nurses hate it because the alarm keeps going off. Or we have never seen a baby who did really well and we had to change. I'll be very happy if a large proportion of audience belong to the category that I just put it out, where we can explore and learn how to really understand this mode, and how to troubleshoot and what we are doing right and what we are doing not doing right. The only other point before I close my opening remarks is that just because you have a machine or just because you have learned volume targeted in this session, it's not a reason to just persist with it if your baby is not liking it or not this thing. Yeah. So with that, I think uh, Dr. Kirtana, isn't it?
Yes.
Presenting
Yes.
session is open. Thank you.
So, insights and inputs, and I request for Kirtana to start the presentation, share the presentation. And Dr. Nitasa and Dr. Jagan, I request both of you to actively engage in the meeting. Whenever the clinical relevance, please give your inputs. So all four can lead the discussion. But to any point of time, the student presentation, throughout the presentation, we can interrupt and discuss so that benefit of the audience.
Sure.
Kirtana, start your presentation. Share the PPT.
Good evening, everyone. I am going to discuss ventilation. Baby of air.
Sound system.
On a station, 30 drugs delivered by emergency. We can manage
Kirtana, your voice is not clear, Kirtana. Kirtana, are you connecting?
They're checking out, just as IT guys checking out. But I don't know how much time they will take. They're checking. I just informed them.
Yeah.
Is it disturbance for everyone actually? Not able to hear?
Dr. Nolini, we can hear you, but Kirtana, my voice is not audible.
Hani, we can hear each other probably, not
We
issue.
can hear Kirtana's voice
We
is
can
not.
hear each other, not able.
Yeah.
So then the presenter from presenter side an issue. Dr. Jagan, I request you to check the presenter side because as the faculty we can hear each other clearly.
Yeah.
Yeah.
Sir, she will run from my laptop, sir.
Yeah.
Not an issue. Even if another presentation there, please read what the sound system is. Same room, two systems should be switched on. Again, that will echo.
Am I audible?
Yes, now you are audible.
Sorry for the interruption. Good evening. Today I'm going to discuss a case-based discussion on volume guarantee ventilation. My baby of M, preterm singleton female, outborn baby, born at 30 weeks of gestation with a birth weight of 1,370 grams, delivered by emergency cesarean section.
I cannot hear the presenter. That's I also cannot hear the presenter. They're not able to.
Yes, she is not audible.
Oh. Okay. Okay. Now I am starting from new laptop, other laptop. Once we can see from this. From starting onwards, it was not audible. Okay.
Sorry to inform you. Just request you to stay for 2 minutes. Actually, Dr. Kirtana is joining from other laptop.
The presentation, if they can send, the Ranjit can handle actually from IT here, the sequence, because
That also can be done.
the voice is there and then from directly we can handle it from here. The issue of the sync.
Am I audible now?
Yes, you are audible.
Yeah, clear.
Sorry for the interruption. Good evening. Today, I'm going to discuss about the case-based discussion on volume guarantee ventilation. My baby, baby of M, preterm singleton female, outborn baby, born to the 30 weeks of the gestation, born at 30 weeks of gestation with a birth weight of 1370 grams, delivered by emergency cesarean section. Indication is in view of preterm premature rupture of membranes with severe oligohydramnios on 28th February 2024 at 7:42 p.m. Baby cried immediately after the birth. In view of respiratory distress, baby received delivery room CPAP and transported to our hospital. Currently, the baby was on low flow nasal cannula. Coming to the maternal history, the baby is born to the 27-year-old G3P2L1D1 mother. G1, the first death at 32 weeks due to the RDS. And it's a female baby, and it was the death at day 2 of life. And G2 is second pregnancy, is baby boy who is alive and healthy. And now the age of the baby is 2 years. G3 is the present pregnancy. Conceived spontaneously, booked case at local hospital at 10 weeks of the gestation and took periconceptional folic acid. First trimester, there is no history of any fever, rash, or bleeding per vagina. Second and third trimester, she took the calcium and iron supplementation and had 2 doses of the tetanus toxoid. She underwent anomaly scan at 20 weeks of the gestation, which was reported as normal. She had preterm premature rupture of membrane 72 hours prior to delivery, for which she was administered with antibiotics. The other investigations done during the pregnancy, like HIV, ELISA, hepatitis B, VDRL, were reported to be normal. Coming to the labor and delivery details, she received 2 doses of antenatal steroid, betamethasone, prior to the delivery within first 72 hours. The baby was delivered by emergency cesarean section, the indication of which as preterm premature rupture of membranes with severe oligohydramnios. Amniotic fluid was clear. Baby cried immediately after the birth. The baby required resuscitation in the form of delivery room CPAP and was assigned an APGAR score of 5 and 7 at 1 and 5 minutes of age. In view of RD and preterm care, baby was transported to the higher center with neopuff. Coming to the postnatal care in NICU, baby was received to the NICU in our hospital at 1 hour of life. On admission, the vitals of the baby are the temperature is 36.2 degrees Celsius and RBS is 68 mg per deciliter. Heart rate is 180 per minute. Respiratory rate is 82 per minute and pulse volume is normal. CRT is less than 3 seconds. Saturation is 84% with room air and 92% with the CPAP. NIBP is 56/24, which the mean is 30 in right upper limb. Baby had respiratory distress with the SAI score of 6/10. The baby is having upper chest retractions, seesaw breathing, and lower chest retractions, which are visible, and grunt, nasal flaring, and xiphoid retractions. So the baby was started on the CPAP with FiO2 of 30% and PEEP of 5 centimeters of water. Due to the increased respiratory distress and increased SAS score of 7/10, increased FiO2 requirement of 35%, PEEP 6 centimeters on CPAP. Chest X-ray was done, which showed the bilateral fine reticulogranular pattern, for which 1 dose of surfactant was given and ventilated. In view of preterm premature rupture of the membrane, CVP CRP culture sent and started on IV antibiotics. Baby was baby was in CPAP for 4 hours of the life. After that, due to the increased respiratory distress and increased SAS score 7/10, as the baby is going to the respiratory failure, baby was intubated with ET tube of size 3 and fixed at 7 centimeters. Bilateral air entry was checked and found to be equal. Under state aseptic precautions, surfactant 1-2, as the chest X-ray is showing the bilateral fine reticulogranular opacities, the showing RDS-like picture, surfactant was administered and the baby was connected to the ventilator with the mode of SIMV plus volume guarantee and pressure support mode with the settings of Pmax of 20, PEEP of 6, respiratory rate of 40, tidal volume of 5 ml per kg, T inspirator time of 0.35 and FiO2 of 30%. On the settings, baby is well synchronized with the ventilator and has an adequate chest rise with minimal retractions. Baby's spontaneous respiratory rate is 50 per minute and maintaining a saturation of 95% on right upper lip. On auscultation, the air entry is equal on the both sides and there are no added sounds. Baby was on mechanical ventilator support for 18 hours. And baby was extubated and kept on the non-invasive ventilation with SIMP mode for 70 to 78 hours and then NIV CPAP mode for 28 hours. And then gradually weaned to the HFNC and then to low flow nasal cannula. Currently, the baby was on low flow nasal cannula. This is the picture of a baby at the time of admission. Before administrating surfactant, this is having a de-recruitment of the lungs. And this is after giving the surfactant and keeping on the ventilator with SIMV plus volume guarantee mode. There is an adequate expansion of here in this second X-ray. There is an adequate expansion of the lungs with the visible 7 to 8 posterior rib spaces. Coming to the ventilator management, up to 4 hours of the life, the CPAP trial was started. Up to 4 hours of the life, the CPAP mode was started. And after that, as due to the increased respiratory distress, the baby was connected to the ventilator with the SIMP and volume guarantee mode with a Pmax of 20 and PEEP of 6, FiO2 35 and rate of 40 with the tidal volume that is 5 ml per kg, 7 ml. And after 19 hours of the life, but as the distress was settling, baby was weaned to the NIV SIMV mode with a Pmax of 18, PEEP of 5, FiO2 of 25 and rate of 35. At the day 3 of life to day 3 and day 4, the baby has required NIV SIMV mode with gradually the pressures and were decreased and FiO2 was also decreased. And at the day 5, baby was shifted to the NIV CPAP mode with FiO2 of 23%, PEEP of 5 and Pmax of 12. And then at day 6, baby was connected to the HFNC. Baby required HFNC for 2 days. Now the baby was on LFNC, requiring 1 liter per minute oxygen. Coming to the anthropometry, the baby weight at birth is 1370 grams. Present weight is at 1340 grams, which corresponds to the 50th percentile on the Fenton growth charts. And head circumference is 27.5 at birth. Present is 28, which also corresponds to the 50th percentile. Length is 43. The length is same at birth and present, which corresponds to 90 to 97th percentile. There is nothing significant in general examination. Anterior fontanelle is 2 into 2 level and it's a pulsatile. There is no cataract, subconjunctival hemorrhages and periorbital facial. There is no facial dysmorphism and the skin. There is no jaundice and pallor. Umbilicus, genitals, anal orifices are normal. On at day 5 of the left, baby was on HFNC with prongs fixed appropriately and the leak is audible. There are no evidence of trauma due to the interface. Baby is at a flow of 4 liters per minute and FiO2 of 21%. What baby is at a flow of 4 liters per minute and FiO2 of 21%. Water level in the chamber is adequate with distillate temperature of 37. There is no condensation in the tubings. The baby is comfortable with respiratory rate of 44 per minute and has a minimal intercostal retraction with SAS score of 2. The saturation is 92% in the right upper limb. On auscultation, the air entry is equal on the both.
Dr. Kirtana, now the baby is in
Coming to
HFNC.
the serious examination, the baby is pink with heart rate of 158. The peripheral pulses or the bounding with regular rhythm and normal volume. The CRT is less than 2 seconds at the sternum. And peripheries are warm. NIBP is 60 by 30. There is a wide with mean BP of 42 and with a pulse pressure of 29 mm of Hg and no visible pericardial pulses. Heart sounds or S1, S2 present. There is a systolic murmur is present over the right second intercostal spaces, for which 2D echo was done on day 2.
You are visible and audible, Kirtana. Continue.
Other systems, no, just briefly you can tell us, because this is a specific presentation about ventilation on volume target learning. So baby's overall condition, but we are more interested in the ventilator already presented. But current status, to summarize, you can say what is status. Could have been better if a ventilated baby now, and we could have directly bedside when examination 10-15 minutes could have been done. But already baby is stable now. That same all the system and summary you can state once.
Coming to the diagnosis, this is a preterm 30 weekers. Coming to the diagnosis, this is a preterm 30-weeker child of 1.37 kgs, appropriate for gestational age. Female baby with RDS, required surfactant and invasive ventilation with a mode of SIMV and volume guarantee. Had a PDA on day 2 of the life, required, which is a hemodynamically significant with a pressure gradient of 20 mm and requiring the medication in the form of paracetamol for the closure and early onset sepsis. Can be due to the preterm premature rupture of the membranes and feed intolerance due to the sepsis.
Sir, can we go to bedside, sir? There is a baby on ventilator, invasive ventilator with volume guarantee. So that we can.
Now is not the baby. Now
This
the
baby is
baby
not.
is not on volume guarantee. Now volume guarantee. He is on the SFNC.
Sir, can you pardon, please?
Sir?
No, you can-
Are we to understand? You want to take the visuals to the bedside of the baby? Is that what you were saying?
So normally what we do actually, I don't understand, if the baby is already ventilated on volume guarantee, we could have
Baby is now
presented that.
off ventilator, right? Yeah.
This baby is not on ventilator. He is on
If
low
the
flow nasal cannula.
But there is another baby, sir, which baby is in ventilator and currently on volume guarantee. The baby was admitted in the afternoon time only. So that we have another case which we can show because he was prepared already on this premature baby. So we could not present on that case. So on bedside, we can show that volume guarantee case.
Till part of the presentation, I will request both the faculties, till now the presentation, the beginning,
Yeah.
the sequence and the winning, we can discuss from here. And for the few of the knobs and bolts and knobs to understand about VG for the audience, we can go directly to machine once can. But the clinical discussion should happen on this baby. And the learning of the machine we can do on that other baby. Should not be.
Yes, sir.
I agree. Yes.
Thank you. Thank you, Kirtana, for a nice presentation. Some of the things I want to tell you.
Yes, sir.
See, you told that this baby was an outborn baby. I think so. Baby was born.
Yes,
This is
sir.
outborn baby.
Yes, sir.
Yes. This baby was outborn. Baby was born outborn and required delivery room CPAP.
Yes, sir.
And baby was transported with TP resuscitator. One important thing to note: whenever you talk, never tell Neopap. It is the brand name of a company actually, Fisher and Paykel. Just talk about TP resuscitator. Baby was transported in TP resuscitator.
Okay, sir.
These are the few things I think we should be very careful. Second important thing, when the baby was brought, baby had respiratory distress. Initially, you started with CPAP. Maximum pressure required is around 6 centimeter.
Yes, sir.
And baby was having increasing respiratory distress, and you started the baby on mechanical ventilation. One important point to note: you have got NIV, you have got invasive ventilation. From CPAP, my question: why you went to invasive ventilation? This baby could have been given to NIV also. Because NIV is a bridge between SAP and invasive mechanical ventilation. So is there any reason you felt that baby will not tolerate NIV, or you could have given a trial of non-invasive ventilation? If I am not wrong, because this
Yes,
baby required
as-
only very short period of mechanical ventilation.
Yes, sir. As there is a increase in respiratory distress and the chest X-ray was showing the features of RDS, according to the European consensus of guidelines, the FiO2 requirement more than 35%. So I thought of giving it in the surfactant to the ensure technique, sir. So I didn't start at the non-invasive ventilation.
One thing, although it is there, European consensus guideline has given the option for giving, that is the requirement of surfactant. So, do you practice Lisa? No.
No, sir.
No, okay. But this is an option. We can keep the baby as, because this baby, what is fell from your presentation, baby did not require mechanical ventilation for a long period of time. You gave us 1 dose of surfactant, baby improved, the chest X-ray improved, there was function of the lung, there was recruitment. So I personally feel if there is a scope of giving non-invasive ventilation, perhaps we can give, we could have given a trial of non-invasive ventilation with Lisa, or even in Ensure. After Ensure also we can give a non-invasive ventilation, because we have got the machine. Because after mechanical ventilation, you started the baby on NIV. My second question, we have got a machine, we have got SIMB plus BG plus PHB, or you can add in your machine, you can give SAMB or SIPB plus BG. Primary mode, what you start?
SIMP plus VG, sir. As the baby is having, as I said, at the respiratory rate 40, the baby is taking 50 respiratory rates, sir. The respiratory rate of the baby is 50. So additional 10 breaths were supported with pressure support ventilation. So I kept SIMB plus volume guarantee ventilation with PSV, sir.
Which ventilator you are having? This PSB plus BG plus, I think Mackay or Servo N. Which ventilator? Which mechanical ventilator you are using this for this?
SLE 5000.
What ventilator? SLE 5000.
5000. Yes, sir.
SLE 5000. You can add SIMB plus BG plus PSB.
Yes, sir.
I don't think so. It's okay. But as you are saying, even that if the baby on ACMB or SIBB plus BG, once the baby's workout breathing comes down, the respiratory rate would also come down. Okay, you can add SIMB plus BG plus PSB. It's okay. Was there any alarm during when you are giving SIMB plus BG plus BSB? Was there any alarm? No.
No, sir.
Suppose there is alarm. You are giving a volume of 5 ml per kg body weight, and ventilator alarm low tidal volume. Then what will you think?
The Pmax which we have set it was not appropriate. The Pmax actually, if the Pmax is increasing, it requires increase.
That is one. Apart from Pmax, you are telling that baby perhaps will require more pressure.
Yes, sir.
I say there may be other reasons. There may be low tidal volume alarm. What are the other reasons?
Flow sensor problem.
No, not flow sensor. See, suppose there is a leak. Most of the ventilators, they cannot compensate leak more than 50% or 60%. So you have to see whether there is a leak or not.
Okay.
Second problem, what are the other problems that you have to see your tube position. Suppose tube is on the one side, so you are waiting only right lung. Then also there may be low alarm, low BT alarm. Third is that there may be some kink in the tube or some kink somewhere. That also can give rise to low alarm. Fourth is that whatever tidal volume, although you have said maybe that tidal volume is not adequate in the tidal volume. About the Pmax, how much max we should keep? How much Pmax we should keep? You are keeping baby on volume guarantee ventilation.
20 to 25.
Why? Why 20 to 25?
Beyond that pressure, there can be barotrauma or volume.
See, one important point is that whatever PIP you set, baby will require that much of PIP to deliver that much of tidal volume. So you are keeping a suppose, and you should know your working PIP before putting the maximum PIP. Suppose your working PIP is 13 or 14, I don't know. Then you can keep 5 centimeter above the working PIP. Why 5 centimeter above the working PIP? Because suppose your working PIP requirement is 14, you are keeping 5 centimeter above 14. That means 19 or 20 centimeter. The advantage of keeping 5 centimeter above the working PIP is that suppose for any reason your flow sensor is not working, that time it will go into the IMB mode. So whatever maximum PIP you have said, that will be delivered to the baby. But the newer generation ventilation, that facility is available, like VN 600, VN 800. Suppose working PIP is 13 or 14 centimeter, it will not increase the PIP more than 5 centimeter beyond the working PIP. But in ventilator, that facility is not there. So you should know what was the working PIP that the baby requires when you are keeping a baby on volume guarantee ventilation. Suppose working PIP is 12 or 13, you keep 5 centimeter above the working PIP. So in case your flow sensor is not working, that time it will not deliver more than that pressure. Suppose you are keeping the baby on 25 or 30, that 30 pressure will be delivered, that will more harm to the baby. So this is the reason you should keep the Pmax around 5 centimeter above the working PIP. But newer mechanical ventilation, that facility is having. How much tidal volume we should keep when you are keeping why you kept 5 ml per kg in this patient? Because we know our tidal volume ranges around 4 to 6
4 to 7 ml per kg. Yes, sir.
So why 5 ml?
This is to as the after giving the surfactant, as the compliance will be getting better, so it requires the less amount of the pressure. So the tidal volume was set at 5 ml per kg. Sir.
See, tidal volume, we know that in preterm baby little bit when you are using VG, in most of the men there is a flow sensor. That flow sensor is same for a term infant or preterm infant. So when you are keeping a flow sensor, it will add some dead space. Actually, in a preterm infant, to compensate that dead space, you keep tidal volume little bit on the higher side than the term infant. Okay. Here you don't have to think about the tidal volume, because whatever tidal volume is, there is the pressure will be regulated and adjusted as per the tidal volume. If your tidal volume is full and the baby requires only 12 centimeter, 14 centimeter, that will be adjusted by the mechanical ventilator. But in volume guarantee ventilation, if preterm infant tidal volume is kept, it will be on the higher side to compensate the volume loss because of the dead space taken by the flow sensor. I think we have understood what I have told.
Yes, sir.
Bijan sir, sorry to interrupt. Just I am requesting Dr. Kirtana, if we are asking Dr. Bijan or Dr. Rajat is asking about some questions relevant to your case, you slide. If you are sharing the slide, go to the slide where you have documented that. You can stop sharing the slide. If we are asking some question relevant slide, you can display so people will understand the audience.
Yes, yes. You can just display the slide for the setting. What setting we have? Kept. I think you can just. It's not visible. Can you tell?
Yes, sir. Yes, sir. The baby is on SIMB plus volume guarantee plus PSB mode of with the settings of Tmax of 20, TEEP of 6, respiratory rate of 40, tidal volume of 5 ml per kg, and respiratory time of 0.35, and FiO2 of 30%.
Say as what we have discussed, the maximum PIP what we kept. Once you connect a baby to a mechanical ventilator, you can see what is the working PIP. That means to deliver 5 ml per kg tidal volume, how much PIP is required by the baby. So suppose the baby's PIP requirement of 13 or 14, I think this in your baby it was the working PIP was like that. So you keep just 5 centimeter above that working PIP. The idea of keeping 5 centimeter above that working PIP is that suppose for any reason your flow sensor is not working. If you keep the maximum PIP on the higher side, that PIP will be delivered to the baby and that will cause more harm. But in newer generation ventilation, that facility is there. They will measure the working PIP and they will not give pressure more 5 centimeter beyond that working PIP. So this fit is available in VN 600, VN 800 like that. But in general, in most of the mechanical ventilator, once we set the maximum PIP, you first know what is the working PIP required by the baby. And along with working PIP, you add around 5 centimeter. So that if your flow sensor doesn't work, the ventilator will go to the IMB mode. In IMB, whatever pressure you have set, that will be delivered to the baby. Actually, that is to be on the safer side. Second important question is that what we are asking or discussing here. Suppose with that maximum PIP, ventilator is giving alarm. And most of the time in volume guarantee ventilation, we see the alarm given is low VT. I think all will agree with me who are watching this program. So once there is low VT, then what are the things you should come in your, as Kirtana was telling that sir, perhaps my maximum PIP is less. That may be the reason, but you should think for other causes also, like leak. One is leak, and I am sure in most of the ventilator you can see the leak, how much leak is there. So if the leak is maximum, whatever PIP is giving, suppose leak is 50%. If we give 20 centimeter pressure, 50% leak is there. That means only 10 centimeter may be delivered. Second important thing is that suppose there may be some kink in the tube, that will also cause some problem. Third is that your tube is not in position. Tube maybe is in the one side of the lung. That means ventilating one lung. Or sometimes what may be there, that baby is not synchronizing. Like suppose you have set a volume of 5 ml per kg body weight and baby is tachypneic. Once the baby is tachypneic, you will find that PIP, whatever maximum PIP you have said, that will not be there. It will touch the PEEP level. That means the algorithm of the ventilator is like that. If the patient can generate the tidal volume, what we have said, then it will not deliver any PIP, it will deliver only PEEP. In that case, what will you do? I think we have understood what I am trying to say.
Yes, sir.
Then what is the option? That happens many times. You will find the baby is tachypneic, especially in a bigger way. And once the baby is tachypneic, you will find that tidal volume is delivered, but PIP is not delivered. Only the PEEP is delivered.
Bijan sir, when they will go to bedside, when they will go to bedside,
that way we can discuss this case.
Yeah. So a few points, if I can take over at this point. So I think because I'm just going through some of the questions, and for people who have never used volume targeted ventilation, some of what we are discussing, it might be a little bit difficult to follow. So just if I dial back a little bit. So before that, I want to ask Kirtana, did you face any challenge in this patient, or in other situations where you have used volume targeted ventilation? Are you facing any challenge? So you think about it, those challenges, while I answer one or two things that has been posed. So somebody has asked, what is the difference between volume guarantee and volume targeted ventilation? So volume guarantee, see, volume targeting is that these are all patient-led ventilations or patient-triggered ventilatory modes like SIMV, SIPPV. So instead of we setting the pressures and mandating that pressure is delivered. So if you set 20/5, that has to be delivered, and really don't care what tidal volume baby is achieved. The disadvantages are two. One is that you might have over distension, and you might have, if you're not generating enough tidal volume for the lungs to open, and so you might have heard about the term open lung strategy. So that is the safest way of ventilating, if at all you're ventilating mechanically. I agree to the point that non-invasive probably could be considered in a lot of situations. So the opening and closing, so the atelectasis and opening, so you don't generate enough PIP, enough tidal volume, and then you increase the settings, then you do a blood gas, and then you decide this is not enough, and you go up, then you open, then you close. So that causes a lot of damage to the lung. So ventilator-induced lung injury, one of the more common mechanisms is rather than volutrauma or barotrauma, the atelectator is what is seen. So volume targeted ventilation is that you target a tidal volume. I want 4 or 5 ml per kilo to be delivered, but I will allow a permissible upper limit for the pressure, and the machine tries to deliver that volume within the parameters you have set and will self-wean. So suppose surfactant starts working, the pressure, the P max or the PIP that you have set will not be used. It will wean. So you don't have to go and change anything on the machine or do a blood gas and then see. So that is the basic principle. So then the terminology of what the machine says, for example, in Drager ventilator, volume guarantee is the term that is used. In, for example, SLE ventilators, there might be TTV or TTV plus, for example. It is not just the term that is different, but for example, email is a usage, and then Gmail and Yahoo Mail are all different forms of email. So that's what you can think about it like that. It's a slightly different way of modulating your pressure and how what protection you have against over distension, etc. It varies from one mode to the other in the ventilator, this thing. So I think that was one of the question. The other question I think has been answered. I'm just going to underline that fact that how do you choose the initial settings? So initial settings, you decide on a targeted tidal volume of somewhere between 4 and 5. So slightly higher in very small babies and slightly lesser by 0.5 ml in slightly bigger babies. And then usually you stand next to the machine, probably start at 25. Okay, and see what pressure is required for that tidal volume to be delivered. Okay, so in a few cycles, in a couple of minutes, you will know that baby is using only 18, for example, correct? And then you can set +5, as Dr. Bijan was saying. So you set somewhere around 23, 22 like that. And then the baby would rarely need to use that if the compliance is going to improve and improve. Okay, so the problem with people or even us when we started using this mode of ventilation is that we were very scared. Small babies we used to ventilate on 18/5, 16/5, 20/5, but none of us had this courage of starting. So you need to be bold and start. Then the other thing is to ensure that you're using the right machine. So lot of volume targeted ventilation modes will not be useful for a neonate. So you should be using a neonatal ventilator dedicated. Otherwise, it doesn't calculate the tidal volume in small babies. So the other thing Dr. Bijan mentioned, which I agree, is the low tidal volume. So you presented a very easy kind of scenario where these challenges you did not face. So apart from whether there is a huge leak, the leak will be either the tube is low or the lungs are still stiff. You've not given adequate surfactant. So if lungs are still stiff, there'll be leak. If the sensor is not facing upwards, if it faces downwards, so it should face upwards. Otherwise, what happens is the condensate in the circuit actually clogs the the sensor surface. So if you keep it facing upwards, that condensate clogging the sensor is less of an issue. And obviously, do not ignore that alarm that is going on. There might be a pneumothorax, there might be pulmonary hemorrhage, there might be a tube displacement. As Dr. Bijan was saying, the tube might have gone to one side. These kind of things. So it is important to understand why we use volume targeted ventilation. What are the initial settings? What are the upper and lower upper limits that we set? And how do we ensure that whatever targeted volume you want the machine to be delivering is delivered? So these are the parameters. I think this will answer many of the small questions that have come up. The other important point that I want to make is that in smaller babies, do not challenge them with SIMV. See, that baby has a natural frequency of wanting to breathe at 50 or 60. So there's no point in saying that, I'll be little bit, I want you to do better. I'm going to support only 40 breaths and the rest of the 10 to 15 breaths you manage on your own. Okay. I think PSV kind of supports it in between. But if you're using a ventilator which has an assist control mode, which is like an SIPPV, all small babies should be on SIPPV to start with. And what you will see is a baby who's breathing at 50, 60. If your mode of ventilation or your settings of the ventilator is good enough, it will start breathing at a lesser rate. So it will start, gravitating towards the rate of 40. Your baby hardly was, breathing much more than 40. So I think that baby was a quick one to wean off, but it's not always the case, correct? So, some babies require a little bit more. Choosing SIPPV or an assist control mode, choosing a Pmax to start with of 25, but staying next to the baby and recalibrating that to +5 of what you need to do, and supporting all the breaths, as I said, with the mode of ventilation is I think is vital. The only other thing I would ask you was, I mean, we're not going to. So a lot of questions are like, why did you not just do CPAP? Why did you wean to this? I think for the purpose of this discussion, this topic will not go into that. There might be other situations where we discuss whether we should have gone for non-invasive, whether we should have gone for this mode. So we have chosen volume targeted. We'll stick to that. Okay. So those are the points that I wanted to make. And if I come back to you, Kirtana, with this baby or another baby you have had on the unit, have you faced challenges of either not adequately ventilating or not adequately oxygenating, or having trouble either weaning the baby or starting the baby on a volume targeted mode, rather?
Once alarm was came as the Pmax was low, sir. So that thing only, sir,
Okay.
for one baby.
I think some few questions were on about leak. How much leak we should tolerate actually? It depends on the ventilator. Babylog 8000 plus, they cleared up to 50% of the leak can be compensated by the ventilator. But the newer generation ventilator like VN600, VN800, they can compensate up to 80%, 80 to 90%. How they compensate 80 to 90%? Because if you see the newer generation ventilator, what they are having automatic flow. Their flow is auto-adjusted. Like in VN600, especially Babylog 8000 plus, there you have flow is manually adjusted. But those ventilator who are compensating the flow, actually, they adjust the flow according to the need. Suppose there is leak, they increasing the flow. So that's why you may find the bias flow on the higher side. So in Babylog 8000 plus, they claim that up to 50% leak that can be compensated. But the newer generation ventilator, even 80 leak be compensated. And second important thing, yes, tell.
A flow regarding the leak compensation, the different companies they claim differently. For the users, I will suggest after going through the manuals and after going through the respiratory trials, they all put a caution. If a baby with more than 40 to 50% leak, you readjust what is the cause of leak. Where is the end point of leak? Peritubular, peritubular, somewhere the probe disconnection in the humidification chamber, correct it and try to get it lower. Because how much they compensate. Even the SLE claims 40 to 50%, SLE the higher generation 6,000. The VN 500, 600 says 62% to 80%, but practically they fail to perform after 50% leak. So if the baby is already showing 50% leak, careful. The baby stable baby may tolerate, a sick baby may not tolerate. So be careful. That's the overall guideline I will say. But before going to that, I will request both the faculties for the students to begin with. I'm a beginner. I got a machine of BZ. I got all the modes with me. INB, SIPP, PS, yes. Which one to initiate? If I want to just initiate, both the faculties I will request to guide which mode I will combine with VZ, assist control, SINB, or PSB with VZ to start with. This I will say that all students might ask that question. I got the VZ, I got present trigger. How to initiate? Both your inputs, please.
See, suppose I have got any machine. If it has got SIMB, SEMB, PSB, and VG, the Dr. Nolanly has rightly put the portion which mode to start with. For all practical purposes, whatever is the baby, you start with ACMB or SIPB plus BG. That is the initial mode. Second is somebody was asking how much PIP, working PIP I should take. You don't have to decide the working PIP, because if you have got the BG mode and you have set a tidal volume, then you how much PIP is required to do that much of tidal volume. That will give us about the PIP. The important thing, what are the other parameters that we choose? That is PDP. And second important, although when there is a BG mode is available, you know how much your PIP automatically calculated. But what are the other parameters that we should look? One is chest rise. If your chest rise is adequate, that means whatever PIP has given, that is okay. Third is that disease condition. Suppose you are ventilating a baby with apnea, that means you need a normal PIP. Suppose you are ventilating a baby with a severe IDS, that means working PIP may be on the higher side. Suppose you are ventilating a baby with a mass with hyperinflated lung, that means that time that we may need a lower PIP. So how much PIP you will set, that will depend on the baby's gestational age, disease condition, chest rise, and if you have got the VG, you can adjust your PIP according to the VG. Second is PWP. How much PWP we should keep once I am ventilating a baby? That will depend on 3 or 4 factors. One is retraction of the chest, anterior posterior diameter, disease condition. Suppose baby is retracting a lot, that means we should start around from 6 to sometimes 7 also. Suppose baby is not retracting, there is no minimal, then you can keep 5 or 4 also. Suppose you are ventilating a baby with CPAP, your PWP may be 4. So PWP will an expansion of the lung in the X-ray. Suppose you see that the expansion of lung is hyperinflated, then you have to decrease on your PWP. So that is the way you set the PWP. Next important question is that as a beginner, how much respiratory rate I should keep? Once you are keeping a baby on SAMB or SIPBB, here it is not respiratory, it is the backup respiratory rate we should keep. And one important point to note, backup respiratory rate should be lower than the normal respiratory rate, what is there in the baby. Suppose baby's respiratory rate is around 40, then you can keep 30, 35 like that. Because in SAMB, all the breaths will be supported by the machine. So that is there, whatever respiratory rate you said, that is the working, that is the backup respiratory rate. In the event of apnea, that respiratory will come into action. Fourth important thing is that how much TI, how much TE we should keep. I think Dr. Nolini told me this thing. It depends on actually time constant, but in clinical practice, we do not see time constant more often. You can see the gestational age of the baby. Whatever is the gestational age, that may be the TI. Like gestational age around 35 weeks, the TI will be 0.35. That is the rough. But TI will depend on the time constant. Time constant is a time delivered by the alveoli, inflate or deflate. Suppose a baby's lung is very small, then the time constant is low. That means the respiratory will be on the higher side. Fourth is that respiratory rate, how much respiratory rate we should keep. That will depend on the time constant. As I told you, if the time constant is more, that means time delivered of the baby is more. That means the respiratory rate will be the lower side, like mass, like BPD, like severe pneumonia, etc. But if the lung is small and the time constant is less, that time we need that the respiratory rate will be on the higher side. That is why we say that, can the audience answer which animal has got the lowest time constant or lowest respiratory rate, highest respiratory rate, and which animal has got the highest respiratory rate? Anybody? I think the hummingbird has got the highest respiratory rate, and the lowest respiratory rate, well, elephant, because their lung is very large. That's why time constant is very large. Similarly, when you are ventilating a baby with preterm baby, you keep the respirator on the little bit higher side, like 50. When you are ventilating a baby with a term baby, then you can keep the respirator on the 40. Then the flow. In some ventilator, you have to adjust the flow. In some ventilator, flow is automatically adjusted. In general, whatever PIP you have set, usually we keep the flow at around 4 to 6 liters per minute. How do you know that your flow is adequate? Whatever PIP you have set, if that PIP is delivered by the ventilator, that means whatever PIP you have set, that is optimum. I think as a beginner, when I start a baby on mechanical, these are the few things that we should keep in mind. There are many other things that we should before actually going there, but the few practical points we should think. Next is the tidal volume. How much tidal volume we should set? As I have told you earlier, in a preterm baby, because of the dead space, you keep the tidal volume when you are keeping the baby on the little bit higher, say like 5 to 6 ml per kg. Like if you are ventilating a baby with a BPD, then you may need tidal volume higher side, etc. So tidal volume usually we keep a range of 4 to 6 ml per kg body weight. But once you are ventilating baby less than 1000 gram or very smaller infants, because of the dead space, we keep tidal volume on the higher side. One important point Dr. Nolini was highlighting, the volume loss. It is not the volume loss because of the leak. It may be volume loss that may be peritubal leak, or volume loss may be in the circuit itself. If the circuit, because of the compressibility of circuit, there may be some loss. Even there may be some loss in the humidifier also. Humidifier water level is not optimum, there may be some loss. Usually most of the ventilator, once you start, they compensate for this volume, and the compensation is tested in some ventilator. These things are tested. So if there is leak, as he has rightly said, you see why there is leak, what is the problem, and try to correct it. If there is a leak compensation facility, there is advantage for us because you don't have to change the, otherwise you have to change the tube. Suppose there is 80% leak, baby is not getting anything, then you have to go for change. I suggest once you are ventilating baby, you should actually resist yourself to change the tube very often. It is better not to change the tube if it is not required. I think these are the few things we should keep in mind when you start a baby on mechanical ventilator. Nalini.
Sir, Rajat sir, आपको just what is your take or you how you will buy this? So how will guide?
Yeah,
Got
so,
the
yeah.
simple one mode and how why it is so.
So I think a lot of important points, but for the beginner, and if you want to learn volume targeted ventilation, so this is my advice. So do not start using it for conditions other than the typical RDS in a preterm baby. I think you have one disease entity where you want to learn this ventilation mode. Is this the typical baby that you have presented? You know, a 28-weeker who needs surfactant, who needs ventilation for whatever reason. This is the baby to kind of learn your volume targeted ventilation. All the other ones will need a lot of nuances to be looked into. Suppose if it is a hypoxic failure in a meconium aspiration syndrome, whether it is a diaphragm baby who's recovering post surgery, multiple other reasons why we ventilate, or if it's a neuromuscular condition where there is no lung problem at all, how to ventilate them. So I think the small babies, you need to learn to ventilate them very well, because these are the ones who will end up with BPD, right? So we don't want that to happen. BPD is what we see. What we do not see is that if you over-ventilate with other modes of ventilation in these extreme preterm babies, there'll be hypocarbia without you realizing, and that leads to cerebral ischemia, and then PVL, it might lead to, cerebral issues, neurodevelopmental issues. So Dr. Nalnikant has asked me to give it in a simple form. So I say that practice your VTV on preterm babies who you have given surfactant for a surfactant deficient lung disease. Let us call it that rather than RDS, because RDS encompasses multiple things. So preterm surfactant deficient lung disease, where you've provided exogenous surfactant and you want to ventilate for a period of time, and you want to use a mode which is brain and lung friendly and also doctor friendly because it self weans. So this is the mode that you will use, and you will ensure that the tube is in the right position. You will stand next to the baby, ensure what is the Pmax that this particular baby needs for a targeted volume of 4 to 5 ml per kilo, and you will recalibrate your Pmax plus or PIP plus 5, and then you allow baby to self-wean. But you will look at leak or alarms very carefully, whether it is the machine or the baby or the lung or you that needs to be sorting things out, and you will address that, and you will ensure a particular tidal volume is delivered by troubleshooting like we have discussed in detail. For those of you who are doing more than this, I would really urge to listen back to what Dr. Bijan has said about time constant, about different disease conditions, about where you want to set up a variable variable inspiratory time, a longer inspiratory time, where you want to set, a larger tidal volume. For example, if I'm ventilating babies beyond 2 to 3 weeks of age, the dead space would have enlarged to about 3 ml per kilo. Those babies might need a higher targeted volume, like 6 to 8 ml per kilo. So those disease conditions are difficult ventilation situations. So you can park that. You're all trainees, you're all fellows. I think focus on looking after this really nice. You can give really nice outcome in this kind of 28-weeker 1.3 kilo baby who received 1 dose of surfactant, ventilated for 2 days. You've established feeds by about 7th day, and then this is, I don't know whether you would agree, Dr. Nalikant. This is
Absolutely.
This is one you need to practice on.
Very pertinent message. But I just, before concluding, this is very pertinent. More than that, we cannot agree more. There's very simple advice to the beginners. Dr. Bijan's detailed points and your simple advice. I just want to put one of my experience, which may not be very advanced, evidence based, but we all have ventilated so many years. So this, you may agree with my experience. The point, the way Dr. Rajat told, preterm HMD, a uniform homogeneous disease. So what I observed in my last 15 years, because when I learned ventilator, since then we are using probably BZ last 16, 17 years. All the machines are in different ways. So what I'm saying, uniform disease of preterm, late preterm, term babies, we got a good result. What is our criteria was then auto weaning, quickly weaning, and extubation as early as possible with the least damage by decreasing PCO2, hypocarbia, not inducing hypocarbia, not much injury. That we achieved goal in when the disease is uniform, be it preterm, be it late preterm, be it term baby with meconium or pneumonia. But if it's a uniform bilateral disease pattern, homogeneous, whenever I saw a non-homogeneous disease like meconium aspiration, non-homogeneous. Meconium aspiration, if with the secondary surfactant is dominant, then probably BG worked well. But non-homogeneous, again, we struggled. A pneumothorax existing, one side pneumothorax, other side any other disease. We struggled with it. Auto weaning was not so easy. CDH baby, we did as per recommendation. Martin Kessler has given a beautiful recommendation for all the learners in a tabular form, disease-wise, gestational age-wise, BG ml per kg. We have done that, but whenever the disease is non-uniform, one side CDH, left side, right side lungs, only lungs there, those cases little we struggle. That's my experience. I don't know when your long-term, your experience, how will say, uniform disease, I got a good result, even the term, late preterm, preterm. But same thing did not happen. Even the preterm, with a significant pneumothorax sitting one side, we did not get the same result with a case of HMD also. So that's one of my points, tips I want to say. When you ventilate a HMD, suddenly 2 days after realize that there is pneumothorax. That time don't put on a VZ and expect that VZ will correct all the things. Many other things to be taken care, not just the VZ will take care of all the things. That's my message.
Another message is that I think Dr. Ni were right. Dr. Martin Kessler, one famous statement is that one size does not fit all. That we must understand. Every baby is different. So one of the most important lesson that we should learn when one's ventilating a baby, machine is a software. Your brain is hardware. Unless you know the baby, you know the baby's physiology, you cannot do a good ventilation. Second important message is that if you want to learn the ventilation, you have to be at the bedside. Every baby teaches us something new. Just let me share one experience. Suppose I keep a baby on with RDS, VG, 5 ml per kg. I am seeing that baby's retraction is that much high, but the requirement of PIP is on the higher side. What is the problem? 5 ml per kg, baby is not retracting, but PIP requirement is on the higher side, like 20. What is the problem? Baby is otherwise comfortable. That means this baby does not require that much of tidal volume. That 5 ml tidal volume may be more than the requirement. Then you reduce the tidal volume for 5 ml to 4.5 ml, you find that baby's PIP requirement comes down. So my point is that every baby is different, and you have to look at the baby, what is happening to the baby. What is his pathology? What is his physiology? So unless you know all things, and you have to titrate the ventilation dynamic, because you cannot set a one setting and you just keep you just keep the baby on that setting for a prolonged period of time, because it is dynamic. Every time baby's lung compliance and mechanics is changing, and according to the need of the baby, we have to titrate your setting. What I have said, that is the general settings, what you do in our clinical practice. VG, another important message for all the beginners. Suppose your flow sensor does not work, all your patient triggered ventilation VG is meaningless. Your patient is getting IMB. One important message, how do you know that your VG or flow sensor is working? How do you know? Any participant? That means whether your flow sensor is working or not, we are using graphics. If you see the graphics, there are three in scalar, there are three. One is pressure, second is flow, that volume. Pressure is measured by the machine. That's why even the flow sensor does not work, you will see the display of the pressure curve. But if the flow sensor does not work, you will not see neither the flow nor the volume curve, because flow and volume is measured by the flow sensor. So the one important message is that if your flow sensor does not work, many a times it happens. Sometimes flow sensor is out of order within 24 or 48 hours. Change the flow sensor. Without flow sensor, your BG is meaningless. So I think these are some important practical points that we face in our day-to-day practice, and one should be very careful.
Dr. Nita sir, because probably, Dr. Nita sir, are you there?
I'm there.
You've done so many years of a busy ventilation, volume target, VTB, so many volume target. Because this question I'm extending, because within short time we have to finish, we may not able to go to the bedside. We will arrange a session of bedside demo someday with a completely baby with live all the features. So I'm just extending discussion. You use so many years. Can you highlight some of the benefits? Already discussed so many things. Few of the clinical benefits or bedside benefits when you go is only present triggered. Some babies in BG. What are the benefits clinically as a clinician you perceived so that students should get those experience benefits? What you can say them? What benefit in comparison to a non-VG present triggered ventilation? Because nowadays nobody is doing IMV. Everybody likes to do PTV. But adding VG, what benefit you got from your experiences so many years?
So the most important benefit which I felt as a clinician when we started learning VG many years back was that you are like carefree when you have put the baby on VG mode. So you are not worried about that whether you are delivering a very high pressure causing the barotrauma to the baby. You have decided your VG according to the baby's need of the pressure, and you have fixed a VG, and that will deliver an automatically required pressure to the baby. So that prevents a lot of barotrauma, that prevents the volutrauma, that also prevents the long-term side effects of the chronic lung disease and all those things for the baby. The second important thing which we always see is an auto weaning. So that is a very important thing with the VG mode. So when you have put the baby on VG mode, it will itself start showing the auto weaning. So the pressure requirement will start coming down. So when as the doctor explained about when you give the surfactant, after giving the surfactant, the lung compliance improves and the pressure requirement of the baby comes down. So all these things come down, helps in decreasing the PIP requirement decreases. So it automatically weans off. You don't have to stand bedside and see every hour, every 2 hours that we should come down onto the PIP. We should come down, because it might, if there is a higher pressure, in spite of increasing the compliance of the lungs, there might be a risk of pneumothorax and all those things. So that's one of the very important points which I say. One is this is the auto weaning which is there, and the third important thing which you have explained about the use of volume guarantee mode, very important to use it wherever it works best, and that is the uniform disease where it works much better. Do not use the VG in all the diseases. It might not be working as functional, but when we use it in the important diseases like respiratory distress syndrome, it really works good. So these are the three important things which I would say with the VG.
So, though no bedside, no escape from the bedside monitoring, no escape from the monitoring of the babies and other important inputs given by Dr. Beeson. That's the key part of the volume guarantee or patient-triggered ventilation. The flow sensor not working. That's important. But few things highlighted by Dr. Nitasa. But I will say one or 2 points I'll add. Probably the sedation analgesia a little decreased in comparison to PTV. When I saw the VZ time, we sedated and analgesia used little decrease because self-weaning happens faster. The ABG, doing ABG also, though if a non-VZ babies and VZ babies will compare, probably we are a little less anxious with the monitoring. So we monitored with this SPO2, monitor tidal volume, previous tidal volume delivery and current, and uniformity of improvement when we saw. Probably the few of the ABGs, doing ABGs unit also. It depends on protocol of the unit, but it decreased practically few of the things. So when we use VZ, few of the pneumothorax and intervention of pneumothorax, like ICDs, definitely it's lesser. Though again, I'm saying that physical bedside standing in front of the baby, clinical nursing monitoring, no replacement for that. But after utilizing everything, few of the interventions are less in BG. Clinically, when we saw those things, that's probably helps us when we do BG. And Dr. Rajat, you must have so many years used volume, targeted many things. I will say your tell the audience what is the positive things you observe. And one thing I will suggest again, you clarified in the beginning. For that reason, I'm requesting this again. The last question coming back to us, hunting back after end of the session. The question again coming the how the difference between volume targeted, volume control, and volume guarantee ventilation. Though I try to answer the taxonomy of a volume target taxonomy with a because I try to just taxonomy only registered here. Where if you different machines use Drager group of ventilator, Drager Babylog VN500, then taxonomy they use volume guarantee. If you use SLE group of ventilator, they use TTB plus. If they use market ventilator, they use pressure regulated volume control. BARD, BIP BARD, they use volume assured pressure support. Puritan band is common, they use VC plus. I have written, but I for namesake only I have written. But I want to just clarify. Still, people are asking to clarify between the two distinct taxonomy. Volume targeted are always to remember is a pressure control mode, time cycle pressure control. It is cannot be compared with the volume control, it's a volume mode. To just simply to explain the audience, I will request again so that we will clearly understand we are by giving volume target, we are not.
I think
That's why I want to send a clear message through your explanation.
correct. So that's a very basic question, and I think we need to tell ourselves as much as we are telling our students as well. See, basically there is in babies and in children, we need to start on the ventilator. It has to cycle on and off. Okay, so on is when you send the gases in, and off is when you allow the baby to breathe out. This is cycling. This is time cycled. Okay, there is nothing else that cycles it. Okay, time. So you set an inspiratory time at the end of it, the flow stops, and then the baby is allowed to breathe. So this is time cycled. Okay, then whether it is patient triggered or not. Okay, non-patient triggered is mandatory IMV, whatever we used to call, or CMV. So it's a mandatory compulsory continuous ventilation. So baby breathes, doesn't breathe, doesn't matter. So time cycling happens, and then you just at a set pressure, 20/5, the machine breathes. That's it. So when it comes to patient triggered ventilation, that means that the baby generates a flow, and there are different ways of identifying that flow. It could be from a flow sensor, it could be from a Grasby capsule, it could be from, multiple other new things which are coming up. So the baby somehow the machine learns to listen to the baby's breathing effort, and it synchronizes. So it's a synchronized mode. So all patient triggered ventilation modes are synchronized. So far, I think that much is clear. Then all our ventilators are depending on the flow. So whatever flow comes, that is what is, driving the ventilation. What we control is what Dr. Nalini is saying. So do not confuse volume controlled with volume targeted ventilation. So all our modes are pressure controlled still. So that is what we need to say. It's a pressure mode of ventilation. Okay. So, but what we have found a way of doing is in the pressure mode, we target the volume, but allow certain parameters of the pressure the machine can decide depending on the baby. Okay. So it is all TCPS, time cycle pressure limited or pressure limited. It's a TCPL mode if you want to be very specific. Time cycle pressure limited, but volume targeted. So you're targeting a particular tidal volume. Okay. Then comes what is volume guarantee, what is volume assured, what is targeted tidal volume, what is targeted tidal volume plus, these are all copyrights. So Draeger has copyrighted its VTV, that is volume targeted ventilation mode, as volume guarantee. It doesn't mean that volume assured is not as much as a guarantee. Assurance is like life assurance. Guarantee is like बिल्कुल मिल ही जाएगा, ऐसा नहीं है. So it is a different term that each company is using because it's copyrighted. So for example, targeted tidal volume TTV and TTV plus, there is a difference. It's not that there are no differences, but I think for the purposes of this class, do not go into the differences. So you have an SLE, has TTV plus, you use that, that is a volume targeted mode. If you have a dragger machine, that is a VG mode. And you have other machines now like Mackey, and multiple machines are there, Humming View and things like that. They use slightly different terminologies. And so the smaller differences is whether it looks at the last breath and reduces the PIP drastically, or whether it is going to reduce by 5, whether by 3, these are the differences. Whether it is going to compute just exhale tidal volume and talk to the machine, or is it going to, calculate the difference between inhaled tidal volume and exhaled tidal volume and come to an algorithm and inform the machine to adjust the pressure. So subtle differences are there, and every manufacturer will claim this is more baby friendly, right? So you just need, if you have 1 or 2 ventilators, you please go through the entire manual, talk to the relevant tech person, understand what it is. Very, very, very important. If you are a combined PICU, NICU kind of model, when you're moving ventilators in between, it should be a neonatal ventilator, because the sensor has to be at the ET tube. It should not be at the machine. So adult ventilation sense flow at the machine as well. So it has to be at the Y of the ET tube, and the sensor has to be there. Closer it is to the baby, the better is the accuracy of what you're doing. So I hope I've not left and I've given some kind of pointers there.
We lost for a few seconds. It's okay.
Nalini?
This makes sense. Actually, we understood the process of the basic taxonomy and classification. So it little cleared what is the difference in functionally they are, and the broad group of this generation of classification. And your final message: what are the terms you use the machine or the company may be using? But before using, at least we should understand the basic principles and how to apply. That's the rule applies to every mode when we initiate actually to learn the same thing. But overall our experience wise, if we used all three available in India, all 3 or 4, if we know how to use properly as per manual instruction, they all worked well. It is not one is superior than other. Though very, very small babies, 500 grams, 600 grammer baby, or below 750 grammer, by default we are preferring or Drager system of ventilator, Drager group of, I'm not saying Drager one ventilator over others, because of the dead space of the flow sensor among all the machines. The flow sensor dead space is 0.6 ml, which is very, very small in the Drager group of ventilator. Others also related same 0.9 ml to 1.25 ml, but for 500 gram baby, 1 ml dead space each, 2 ml per kg. Also we have to remember we're using very small baby. So for that reason, sometimes it works well, but machine wise, performance wise, it's all, if we know, understand, it's good. One question to our NIV man, Dr. Bijan, who is very fun NIV. So somebody has asked question, can we deliver VZ with NIV? And another question came, which I'm deferring for next session. Our moderator, Dr. Jagan, has asked HFO plus VZ experience. Yes, we do it routinely now with 3 different machines, and we are getting very new experience with this HFO VG. But we are not discussing here. We will discuss later in the HFO session, HFO plus VG. But here the current question of NIV, can we deliver VG? That's a question from my audience with Dr. Bijan to answer.
See, thank you, Dr. Nalini. In NIV, actually, whatever NIV machine is available till today, whatever NIV, non-invasive positive pressure ventilation, these are all non-synchronous. But there are machines which is synchronous NIV. But if you talk about whether we can combine NIV plus VG, right to the best of my knowledge, there is no such ventilator. But there are ventilators which can actually synchronize the patient breath, that is synchronous NIV. Synchronous NIV may be done by the flow sensor or by the pressure sensor. There are machines which can do like Hamilton. They have got NIV synchronous, they synchronize the pressure only. Like Julia ventilator, they can synchronize the flow. But once you use NIV, there will be a lot of leak. That is why they say that flow sensor might not be working. So, and whatever experience I am having, I am using non-synchronous ventilation for more than 5, 6, 7 years. What we have seen, there is not much difference between synchronous versus non-synchronous. In fact, we are using non-invasive high-frequency ventilation also. If you see the difference between synchronous, non-synchronous, or non-invasive high-frequency ventilation, synchronous, according to the evidence, that synchronous may have got little bit of age over the non-synchronous. But if you do not have the non-synchronous, synchronous machine, you can use non-synchronous. Only thing is that, and now some of the newer machines which are coming, their flow is adjusted. That means in NIB there will be a lot of leak. There will be automatic leak adjustment is there. So, but the VG plus NIB, that ventilator is not available. Whatever ventilator available, synchronous, non-synchronous, and automatic adjustment of the leak. Like as I have said in invasive ventilation, there may be leak compensation facilities available. Now the newer NIV machines, they have got the facility for leak compensation also. They increase the flow and that way they actually compensate the leak. But NIV plus BG, that kind of machine is not available. That is very difficult because there is a lot of leak. They cannot deliver that much of tidal volume. It will be very difficult because once you keep a baby on mask or prong, there will be a lot of leak. With that leak, to deliver the targeted tidal volume, it will be very difficult. Maybe in future it may come.
The basic we won't work with leak, and with the NIV leak is imminent actually. So it is very difficult physiologically till now not compatible. Only flow sensor delivery system comes. That will be different later with the delivering little. Currently, we don't have the facility as per my knowledge also. So, but quickly to go ahead, one clinical audience. Sir, Vision sir, one quick clinical question. All three faculties I'm asking, including moderator. One question came from audience, but quick, that part we left actually during discussion. You are put on a busy mode, you are happy. But how to wean and extubate? Weaning, extubation is a different story. At what cutoff we should extubate and how to wean. That's the two practice points. Each one, if you'll say, that will be useful for the audience. That question is relevant, I feel.
So I'll go first. So I think ventilation is more than just what the lungs look like. Am I audible?
Yeah, clearly. Some issue again we lost actually. Boys, Dr. Anajit.
Am I audible?
Yeah, you're audible.
And just what the lungs look like. Yeah. Ventilation is more than what the lungs look like, if I'm audible. So I'm assuming your baby is not on multiple inotropes, neurologically stable, your sepsis is not overwhelming, you don't have coagulopathy and all those things. You know, we might have a small spot where the lungs look great, but all this is happening, then you're not going to be brave enough to extubate, correct? So you will have to be in a bad position. Otherwise, if you're using the PIP used is not more than, let us say, 5 or 6 of the PEEP. Okay, and the baby is otherwise stable. So that is the time to extubate. Otherwise, if you're only doing, you know, you have set at 20, but the baby is using, let us say, only 9 or 8 of PIP and, you know, PEEP, it's very close. And the baby is going to tire out because you have a long dead space of the ET tube. So it is like keeping the baby on a ET CPAP, okay, which is not a nice thing to do beyond the time where you want to test for extubation. So other things will be based on the unit policy, whether you want to see for the trigger, whether you give a trial of CPAP for a few minutes and see the work of breathing, etc. And then you can decide. So if the required pressure to generate those tidal volumes are coming very close to PEEP by about 3 to 5 centimeters, you can easily extubate the baby. Or if you want to think another way, if you look at the map that is delivered, if the map is around 6 to 8 centimeters, that kind of map can be easily delivered by your CPAP, correct? More or less about 6 to 7 can be delivered. So you can extubate. Thank you.
I think Dr. Rajat has already told, once you go for weaning and extubation, first of primary disease should be corrected. Baby should be off inotropes. Baby should have good spontaneous respiratory effort. Electrolyte should be normal. After that, what are the settings from where you can extubate? As he has rightly said, if you combine all these PIP, PWP, TI, that will come under MAP, mean area pressure. As a general rule, if the baby's weight is less than 1000 gram, any map less than 8, baby is suitable for weaning. More than 1000 gram, less than 9 will be optimum. Less than 8 and less than 7. Second important thing, as he has said, if you see the PIP, usually 10, 12 or 13, it depends. Suppose it's a bigger baby, even 14, 15 PIP baby can be extubated or baby can be extubated and weaning can be started. Respiratory rate, once you are keeping the baby on SIPPB or SAMB, you don't have to think for that. PWP, any PWP 4, 5 or level 4, that is optimum. So with this setting and with the baby is improving, primary disease is resolved, electrolytes are normal, nutrition is good, secretion is manageable. That is one of the important point. Once you are ventilating a prolonged period of time, there is a lot of secretion. Secretions are manageable. You extubate the baby to AV or CPAP, whatever. Study says that NIB is better than CPAP, extubation failure is less. I think that is the message I can.
So one of the important messages which I want to give, I think both Rajat and Bijan sir has told most of the thing, but a lot of fellows ask this question: can we actually extubate the baby from VG? So yes, it is absolutely fine to extubate the baby directly from VG. So there is no need to wean off further by removing the VG and coming down from SIPPV to SIMB and then coming down onto the pressures and all those things. It's not required. So please be comfortable once you are onto the minimal achievable pressures, rates and FiO2 and rest of the things are comfortable for extubation and baby is ready for extubation. VG of 4 to 4.5 kilo, 5 ml per kilo is more than good to extubate the baby directly. So don't be hesitant. It is definitely a directly extubate is what I would say.
Another last message I want to say, once you are intubating a baby, always you should think when I should extubate. That should be in your mind. That I said that in Mahabharata, Abhimanyu knew how to enter the circle, but Abhimanyu did not know how to come out of the circle. To ventilate a baby, it is very easy, but to come out of the ventilation, sometimes it becomes tough. So always think that once you are intubating a baby, try to think when you will come out. That is our challenge.
So thanks the presenter, thanks all the faculties and moderator. I will ask moderator Dr. Jagan to say a few words. The presentation very briefly. She presented the case with touching all the aspects of ventilation. Discussion happened so well with the participating so many questions. Participants asked, we answered. We hope to their queries. Few of the unanswered questions there. We will for clinical session again. We'll answer. Try to answer. Here before each session before end of the session, I give few of the books and chapters tips. So here I am saying, if volume guarantee you listen to understand better, read neonatal mechanical ventilation, 1 or 2 textbook. Previously you asked, one of the faculty suggested, read the Bible of neonatal ventilation, Goldsmith book, 1 chapter, volume guarantee, if you willing to learn. Second, 2 of the references I will give, a practical guide to neonatal volume guarantee ventilation written by Kleinberg and Wheeler. The two articles are there by them. Their group, Kleinberg, Wheeler, and Colin Morley. They've written 2 articles, well written. How to initiate, how to set the working pressure, how to set with the different PSBBG, SCBG, or SIMBBG, how to troubleshoot the alarms, and when to choose to decide to wean and extubate. This is like a guideline format given in these 2 articles. Along with that, additional article Martin Kessler, who has guided us with disease. When we are saying no single ventilatory panacea for all the disease, No single shoe fits to all the disease or process. Similar principle is given various recommendations. These 2 to 3 articles plus the book chart of a neonatal ventilation Goldsmith you will read. You will try to understand, but understanding one way, practicing and getting the skill is later. You can apply bedside learning from your teachers, your guides, from your colleagues in the unit. That will help from the long run and help you directly understanding the problem and how to optimize same ventilator setting in the bedside. Those learning you have to do from your guide and teachers and your colleagues. So with that, probably I'll request again Dr. Jagan was throughout the session was there. In my few words, you can talk about the case. Then we will one-on message we will take from the faculty. Thank you for staying so late. And I will, with taking one message, we will close the session. Please, Dr. Jagan. Thank you for taking the call to present. And please, few words from you.
Thank you for giving this opportunity, sir. So a lot of things were taught by Dr. Nalini sir and Dr. Rajat sir. And I want to emphasize, and again, for the students, that volume guarantee is brain friendly and lung friendly. It prevents wide fluctuations in PCO2. So it prevents indirectly IVH and also cystic PVL. And it prevents pneumothorax and many systemic meta-analysis. Also, the evidence is that on volume guarantee, we are happily, we can sleep and also we can extubate the baby early. So the BPD risk also has been decreased. So volume guarantee for the beginners to learn, preterm baby, ideally preterm baby requiring surfactant is the best baby to learn. Thank you all.
Thank you, Dr. Jagan. Dr. Rajat, one message, please, because you well explained many of the facts, but one message to the students today.
I think this is the mode to learn. I think forget everything else. Get your volume targeted ventilation mode really good, because a chunk of babies you'll be looking after are surfactant deficient preterm babies who might be septic also. So this, do not be afraid, but do not just be comfortable with ignoring alarms and just somehow getting through 1 or 2, 3 days of ventilation. So get it right. That's the message.
Thank you. Dr. Bijan sir.
Once you are ventilating a baby, you should be at bedside. Baby will teach you what to do. It is a baby which will tell you what should be done. If there is tachypnea, that means your ventilation is inadequate. If there is leak, that means you are not adequately ventilating. If there is retraction, that is increased work, that means your setting is not proper. So it is I think I will request all the new beginners, whatever ventilation you do, you should be at the bedside. See what the baby is, how the baby is behaving. That is the message.
Dr. Dasa.
One message that whenever volume guarantee is not working, when you are listening lot of alarms, when there is a problem, just don't only focus that the pressure delivery is a problem. Always remember there are many causes for which the volume guarantee mode cannot deliver. There can be a leak, which can be there due to pneumothorax, tube displacement, or thinking of the tube. There are so many reasons. So remember those reasons in mind and try to get rid of those problems than getting rid of VG and switching over to SME and SIPPB mode. So try to work on to the causes why VG cannot work, and it's easily rectifiable. That's all.
So lot of learning, great inputs. Thank you all the faculties. Before concluding, one message from my side. I will say, agree with Dr. Bijan's message again, little to elaborate. Don't ignore the master teacher, the baby in front of you. In isolation, nothing happens. We don't treat lungs only. We treat the baby. If we are treating with lungs, and we are dealing with a neurological disease or a PDA, that's also need to be addressed. So bedside, when you are going, address the babies, all these issues. The master teacher will teach you. That's so this learning is for busy, but it applies to every classes, every bedside assessment. Wholesome assessment of the baby when we are going to the baby bedside. That's essential to get the result in any mode, in any therapy. That's only the message. Thank you all. Thank you for this great input, great teaching, and thank you all the audience till they are also staying late and learning all the things. Thank you all.
Thank you.
New ventilator session on PPHN we will do next week. So we'll coming with a new session of PPHN, the ventilation strategy with a directly bedside live. Next time we will go for no presentation, bedside live PPHN with ventilation. Thank you all. We'll see you next time again.
Thank you.